evaluations at the end of the session because that's how we get credit for the grand rounds, and if that's not done, then we can't continue the series. Most of you are familiar with how we take into account numbers for grand rounds now. The number is on the screen with the event ID. Please call into that number. If this is the first time you're calling into that number, you will get a text back asking to identify yourself so they can give you CME credit. We ask that all medical students and residents also use that, even though you may not require CME credit, because that's how we count our attendance for grand rounds. Having said that, hope you enjoyed the talk. Here's Dr. Wood.
Thank you. It's my great pleasure to introduce Dr. Sucheta Joshi. I've had the pleasure of getting to know Dr. Joshi on a committee that's actually related to the talk she's giving on telehealth and ECHO, Project ECHO. Dr. Joshi is our visiting professor in neurology here, which we got through the American Academy of Pediatrics, so we're very thankful to we have to acknowledge the American Academy of Pediatrics. Dr. Joshi was actually born in the U.S., but then returned to India and did her preliminary medical early education, then preliminary medical education in India, medical school, pediatric residency, and then came to the States, did her residency at UCSF, University of California, San Francisco, went on to go to do a fellowship in neurology at Stanford, and then a subspecialization in
epilepsy.
In epilepsy, yes. She's also done a master's in clinical research. After finishing that training, she went to the University of Michigan, where she's been a faculty member there ever since. She's really provided a great leadership nationally on this Project ECHO, which you hear about, and training general pediatricians to improve their ability to care for children with epilepsy. So, no further ado, thank you, Dr. Joshi.
I think I have a mic.
Your...
Yep. Is this turned on? Oh, you want me to use this one?
For the room.
Oh, okay.
You can leave that one on though. Sorry, you have to two.
Wait. I'm going to get two?
What did you do here? What did you do to the microphone? Muted it. Alright, so got another pocket there.
Oh, yeah. I feel like I'm with the FBI or something.
Right.
You know what? I'll leave it.
Oh, are you just gonna stay there?
Yeah. Can you hear me? First of all, I want to thank Dr. Wood for this absolutely amazing opportunity to come out here and spend these couple of days with all of you. And thank the American Academy of Pediatrics for making this visiting professorship in epilepsy possible. What I'm going to talk about today is a little different from what we've been talking about all morning. So I am a pediatric neurologist and spend most of my clinical time taking care of children, infants, adolescents with epilepsy, including very difficult to control epilepsy. But over the past 4 or 5 years, I have also developed an interest in making this epilepsy care something that children who don't live close to our institution can avail of through different healthcare technologies, particularly telemedicine. And that's kind of where my path with Dr. Woods crossed through the National Coordinating Center at the American Academy of Pediatrics. And what you're going to hear today is a bit of telemedicine in the world of medicine and some of my work, particularly some of the work we've done in Michigan. So I'm just going to go through just the usual disclosures. So what I hope to do in this lecture is review the role of telemedicine in improving access to healthcare, discuss the use of telemedicine specifically in providing care for children with epilepsy, and then review a couple of models of telemedicine and telementoring which are a little different. So this is basically the bones of the talk, an overview of the access and role of telemedicine in pediatric care, the Pediatric Epilepsy Telemedicine Clinic, and telementoring through Project ECHO. Now, telemedicine is defined as the use of medical information exchanged from one site to another via electronic communications to improve a patient's clinical health status. This is the definition that the American Telemedicine Association has provided. We use the word telemedicine in the context when direct patient care is delivered. There's a broader term that is used called telehealth, and this is a more all-encompassing term that includes telemedicine. It also includes other health-related services that use technology, such as health information sharing, patient and professional education, and what's called mobile patient monitoring. So, just to review the different types of telemedicine, so there's something called synchronous telemedicine, which is live video conference that has a patient at one end and a provider at the other end. There is asynchronous telemedicine, which is also referred to as store and forward. So this is where clinical information is stored in the form of either medical information or a picture, an image, and then it is forwarded typically to a specialist to review. And then there is also the whole concept of remote patient monitoring, which I'll refer to in a minute. So synchronous telemedicine, as I said, uses real-time, two-way transmission between the provider and patient. It is commonly used in ambulatory settings, but is also increasingly used in like an ICU setting, and typically is used for subspecialty consultations. Asynchronous telemedicine, on the other hand, is the store and forward system where digital images or data are recorded and stored at one end, and then they are sent electronically to a specialist and they are reviewed. Some examples of the store and forward technology. So this has been used quite extensively in dermatology, where a picture of a skin lesion or a skin rash can be taken at the primary care and then sent to a dermatologist for review and for a consultation and opinion. Echocardiograms are being done with this remote access technology, so we call it tele-echocardiography. And in the state of Michigan, there is a very, very large network of echocardiograms that are remoted in from several sites to the University of Michigan. Similarly, retinal pictures are also sent, and so in the field of ophthalmology, telemedicine using this system is also used. On the other hand, when we say remote patient monitoring, this is the use of mobile technology to track healthcare data. So this can be, for example, in a population of individuals with diabetes. Blood sugar monitoring can be done remotely, so a patient has a way to upload their blood sugars into a system that gets transmitted to the nurse or the NP or the physician, and so they can sort of follow their patient's blood sugars over a period of time without the patient having to actually come to clinic that often. These programs are very popular in the internal medicine world, where the numbers of patients are high, and these are fairly commonly occurring conditions. So blood sugar monitoring, monitoring hypertension, actually looking at efficacy of a medicine after they're started on for their hypertension. Even in weight management, this can be quite a useful tool. Now, in the world of pediatrics, we all face the issue of access and shortages. And the American Academy of Pediatrics division of, or I guess the subdivision of telehealth, actually came out with a paper that emphasized the use of telemedicine to address these very access and physician workforce shortages. The impact of telemedicine is thought to be in improving access to particularly to specialty care, increasing physician capacity, and there's also a thought that this can have an impact on cost, primarily by reducing costs of travel for families, reducing missed work and or school days, and reduction in the utilization of tertiary care services. I'll add another caveat to that travel costs can be reduced for physicians also, particularly specialists who travel to remote sites to conduct specialty clinics, so that cost of travel can be reduced as well. Now, let's just sort of frame this in the context of what the challenge is and why this access and workforce shortage is a problem. So when you look at the pediatric population in general, about a quarter of the children today live with a chronic health condition. And this is not just epilepsy. I'm talking about developmental stuff, epilepsy, asthma, rheumatic diseases, but chronic health conditions. As a result, specialty care is an increasing need. Everybody here knows that wait times for specialty referrals can be long, and this is a pretty common problem. As a result, many children don't get the access to pediatric specialists to get that high quality care that's also coordinated with their primary care doctor. The 2009-2010 National Child Health Survey emphasized some of these statistics, that 15% of US children have special health care needs, and these are more in the range of developmental problems. 23% of US households have with children have at least one child with special health care needs. So I think these are just different ways in underscoring how big of a problem this is all across the country and how great the need is. So families who have children with special health care needs, about again a quarter of them report unmet need for healthcare services or unmet needs for healthcare services. Several parents in this particular survey reported significant out-of-pocket expenses related to their children with special needs. That goes hand in hand with financial problems because of the needs of their special healthcare child. And in many families, at least one parent had to cut back or stop working in order to provide for the needs of these children. So when you think of this, telemedicine is becoming increasingly recognized as a means to improve specialty care, particularly for children with special healthcare needs and those who live in the more remote, rural, and underserved areas. It is now becoming, I won't say it has become, I wish I could say that, but it is becoming an acceptable solution to healthcare access. No matter what study you look at, how small, how big, one of the common themes is there's pretty high patient and provider satisfaction with telemedicine services. And by and large, it does not pose an adverse risk as compared to face-to-face patient care. I'd like to segue into translating these general themes of telemedicine to what I do, which is epilepsy. So again, we've talked about epilepsy is defined by recurrent unprovoked seizures, and about 1% of children in the United States have epilepsy. When you look at epilepsy across the lifetime, somewhere in their life, 1 out of every 26 individuals will have a diagnosis of epilepsy. Talking about the care for children with epilepsy, the primary care provider or emergency rooms are usually the first point of contact when a child has a seizure. However, pediatricians don't feel like they're adequately trained in treating seizures. This was a study done in Michigan where a survey was given out to residents in training who did not feel that their training for treating seizures was adequate. And pediatricians, whether that's a result or whatever, but pediatricians almost always seek consultation for children with seizures as compared with children with other neurological disorders. This creates sort of a supply and demand situation. And a decade ago, it was estimated through a survey done from the Child Neurology Society that there were 1.27 child neurologists per 100,000 children. Now, this is great job security, I know, but that is a lot of children who need neurologists and not enough neurologists. The average wait time for a new patient evaluation, that survey estimated was 53 days. I think it's a lot more than that, with longer wait times in academic settings. And this study projected that not much was going to change in terms of growth over the next 2 decades. So fast forward 5 years later, and it was a very similar observation made by another group of neurologists. And what they found was that supply did not satisfy demand. If you look at, this is just looking at membership in the Child Neurology Society, it has grown, but not grown enough to address the needs of our population. Now, when we look at this, it's almost common sense to think that if we have such subspecialist shortages, there is going to be a bigger burden on the primary care provider, and this is going to be even more acute in more remote and underserved areas. An updated pediatric neurology workforce survey is in the process of being published, and it's at a stage where I'm not able to share the information right now. But one of the highlights of that survey again shows that most pediatric neurologists, upwards of 95%, practice in urban or suburban settings, and very, very few practice in rural settings. So my question is, can telemedicine improve access and provide the same or better care? Again, I'm going to phrase this in using epilepsy as my, as the general framework. And telemedicine for epilepsy has been looked at. This was a study that was done in rural Arkansas at the University of Arkansas Medical Center. It's actually quite an interesting study and what they found. So they had their central specialist hub at the University of Arkansas Medical Center, and they connected to 4 remote sites that ranged from 113 to almost 200 miles away from UAMS. This also included a clinic in a prison. And this is just a picture to show you where the sites were located relative to the University Medical Center. They held a clinic every 6 to 8 weeks. They required that anybody seen through telemedicine had at least 1 annual in-person visit. And over a period of 3 years, they had about 74 encounters. These were all adult patients, by the way, with 24 unique patients. They had all types of epilepsy represented in their sample population. And at the visits, they talked about medical management, discussions about epilepsy surgery, so really whatever the patient needed. It was an extremely well-attended clinic with basically 74 out of the 83 scheduled encounters actually took place. The positives of their experience was the ability to manage a wide variety of epilepsies. Obviously, it was convenient to patients. And just based on their survey, they had a high patient satisfaction. They did talk about possible cost savings, but they were very clear that they did not do a formal cost effectiveness analysis, so it's a little difficult to sort of gauge what the money saved there was. These are also difficult equations to create in terms of, how much money do you really save. So where does this apply, and how does this apply to what I do and to Michigan? So just looking at how the children with special healthcare needs numbers translate from a national level to Michigan. So there are about over 400,000 children in Michigan who qualify as children with special healthcare needs. The prevalence of epilepsy in this population is about 3.1%, which means there are about 13,000 children in Michigan who who are likely to have a diagnosis of epilepsy. I've crunched these numbers a couple of different ways, taking a few different statistics, and it comes to about that number. Now, here is the demand, and here is the supply. There are fewer than 50 child neurologists in Michigan. Michigan, as you can see geographically, is divided into the lower peninsula, which is the mitten-like landmass at the bottom, and then there is the Upper Peninsula, there is one child neurologist in the Michigan UP. So this is a case, it's one of my patients in clinic, sort of, but it's a very common story for what I see in clinic. This is an 8-year-old boy with cerebral palsy and intractable epilepsy on multiple anti-seizure medications as well as the ketogenic diet. The child is partially G-tube fed, requires a wheelchair, and the drive from where this child lives to the University of Michigan is about 150 miles each way. A clinic visit means that the parents miss work, because both parents work, but moving all his equipment, his feeds, his pump and everything means they both miss work, and the child misses school. Here's another example of a 5-year-old who lives in the Michigan Upper Peninsula. I've actually map-quested this, and it's 470 miles from where she lives to where I am. The severity of this child's epilepsy needs clinic visits every 3 months. But the typical scenario is we have a window from June to August to see this kid, and everything else happens over the telephone. There's never I never get to see the child, to see what the child looks like. They have a pretty good primary care facility where they live, so it's usually, just notes going back and forth. So essentially, seeing a pediatric neurologist requires these children and youth with epilepsy to travel long distances, resulting in missed school time, resulting in work days, and a lot of extra expenses for travel and lodging. The kid who lives 450 miles plus away, it's usually a 3 to 4 day trip for them to come down, stay in a hotel. It's all the gas, the hotel money. Yes, our state does assist with some of that, but it's still kind of a logistical challenge. So the Michigan Pediatric Epilepsy Telemedicine Project originally started in 2010 and was funded by the Maternal Child Health Bureau and the Human Resources and Services Agency. The funding was secured by the state of Michigan, and we joined the project in 2012. And the current clinic is funded through a new round of funding active as of 2013. The goal of this clinic really was to improve access to care for children and youth with epilepsy by improving, among other things, care coordination between the patients, their primary care doctors, and neurologists. We were very clear about using the framework of a medical home with the goal of maximizing health outcomes, and of course to reduce the impact on travel, school, and work attendance. So the way our clinic is set up is it's one half day, not per week, it's a half day per month actually, but it's a half day off the week per month. We have the ability to schedule up to 4 return visits. The average has been 1 to 3. And I am able to connect with more than one site during the same clinic session. Now, I have to be very careful that if I'm seeing a patient at site A and then a patient at site B, site A is turned off for site B so that you're not, site A is not listening in on site B. We've not had that kind of a problem, but we just have to be cognizant of doing that. We only do return visits for children with epilepsy. The visits are conducted with a medical professional at the primary care site. And this could be, I have had the child's primary pediatrician, a partner in the practice, a nurse practitioner, and we have also had a PA. So there's been pretty much any medical provider has been able to be at the other end. We conduct a training session when new sites come on board, primarily to walk them through the structure of the visit and also to walk them through a neurological examination. The examination is performed at the remote site by the primary care provider, and I observe it. Sometimes I have to direct the exam a little bit, but it actually works pretty well. Nobody is excluded on the basis of the complexity of their epilepsy. The only exception to this is if a child has an implanted vagus nerve stimulator, which is a treatment modality for refractory epilepsy. We can't program a vagus nerve stimulator across telemedicine, so that requires an inpatient visit. But if we're not anticipating vagus nerve stimulator programming, we can pretty much see anybody. We've followed 3 children on the ketogenic diet. Our ketogenic diet dietitian participates in the visits at our end. And this is really pretty unique because not only does the primary care doctor hear what I have to say, but they get this instant care coordination from a dietitian as well. So the visit consists of a full history, medication reconciliation, which I find very, very beneficial for myself. The examination is observed and recorded. The plan is discussed by all three parties. And from the remote site, we complete a seizure action plan, or an epilepsy care plan, so that they know what to do in the event of a seizure happening. For me, the medicine reconciliation is a big part of the clinic visit. Sometimes a child is put on a new inhaler for asthma that I don't know about. And then, I'll get a call from the parent saying my child has developed new tremors. And then I realize, oh, wait a minute, your albuterol got doubled because for whatever reason, and it's probably the medicine and it's not the epilepsy or a side effect from one of your anti-seizure medications. Or the kid gets put on some other medication which has an implication on their ketogenic diet management. And these are little pieces that tend to fall through the cracks, not intentionally, but it just happens because there is this complex system of communication. And I find this to be extremely useful when I'm directly talking with the pediatrician or the NP or PA, whoever is at the other end. We have a fairly good system of letters going out to referring doctors when we see patients in our clinic, but it's a slow system. So by the time, my dictated note makes it to somebody, they read it, they act on it, it's time for the kid to come back to clinic. So you've sort of lost a lot in that time. Here is the technology that we use. So this is let's see, do we have a pointer somewhere? So that is our Polycom card. That's the camera. That's the screen. And then there's pretty nice audio and video control, and it sits on a cart. So this cart lives in a closet in one of our clinic spaces. I don't do this in my office just because I don't have the space to actually fit this thing in my office, and I don't have enough Ethernet ports to connect and be on my EMR at the same time. We have excellent IT support. There is actually a University of Michigan Electronic Health or eHealth little program and a UFM telemedicine office that provides us with technical support. So here's another picture of the same equipment. And basically what you see sort of three little screens there. So that's the UFM clinic in the top. That's me. Then there is the remote site at the bottom. And that's the telemedicine control room, which is in a completely different building, but we are all able to remote in. Now, we don't use the same technology that Echo uses, which is Zoom. Again, in the world of telemedicine, this is kind of the state-of-the-art, most secure system that we use, particularly because there are actual patients being seen. So this is basically what we use. As I have said before, the advantages here are avoiding travel for families. So the kid that I talked about who drives 150 miles one way, now when I see him in telemedicine, it's one parent who comes because it's a short distance, they can do it between meals. The kid goes back to school, the parent goes back to work. There obviously avoids missing work in school. And again, to say it one more time, this care coordination between the patient, the primary care provider, and the specialist is really invaluable. So to date, we have had 37 patient encounters. We have seen actually 38 encounters and 13 unique patients. Again, we have had an extremely low no-show rate. In the last 3 years, I have had 6 visits not happen. One visit was because it was snowing so hard up in northern Michigan that the family could not even get out of their house. So they were never going to come to my clinic visit down in Ann Arbor. And then there were a couple of visits that were missed because a parent was sick and had to go to their own medical appointments. We have had a couple of families just no-show because they no-showed, but that is definitely the exception and not quite as common in our regular clinic. So in just collecting some information as to how patients and providers feel about their experience, so parents rate telemedicine visits with epilepsy specialists and the primary care provider as very helpful in terms of making sure that the child has correct medications and correct doses of medication. So 100% of the small sample of parents that we interviewed felt this way. 100% thought that the clinic helped parents and children understand the epilepsy management plan, and also helping the primary care provider in. So the parents thought that this model helped their PCP understand their child's epilepsy better. And as I mentioned, getting both providers on the same page. On the other hand, the PCPs thought that, again, 100% of PCPs thought that, this was useful to making sure that the child had the correct medicines and doses. Very similar. Improving primary care provider understanding of the epilepsy management plan. Improving primary care provider knowledge about how to treat epilepsy signs and symptoms. So, it's a very sort of subtle change you see over time. But what you see is the first time you're doing a visit like this, you're asking about, comorbidities and school and vitamin D. And then second, third, fourth visit, before I can say anything, the PCP jumps in to say, so how much vitamin D are you taking? And that's, that is really great to see that care coordination happening, live sort of over time. Again, getting providers, parents, and patients on the same page was big. Identifying issues that need to be followed by the primary care provider. Again, these kind of models are quite helpful. In general, 75% of PCPs agreed that they were able to take a broader role in epilepsy management of their patients due to participating in these kind of telemedicine appointments. The PCPs that we have surveyed have felt that additional subspecialty areas would be useful, more frequent visit options. It's hard for us to, to get a call saying, hey, I think this kid needs to be seen tomorrow, can you do it? But again, as we grow and get more accustomed to doing this, that might be an option. And everybody would like for us to see new patients. That is not a bridge we've been able to cross successfully yet. It's not all simple. Scheduling can be pretty tricky because 2 appointments have to be scheduled at 2 different places. So 2 schedules have to be coordinated. And what happens is the patient doesn't walk into my clinic to check themselves in. So I don't have a way of opening their EMR and starting the clinic visit encounter. Again, this is a very minor issue, but it's a real practical problem. We are developing a video visit encounter in our EMR, so the day that actually happens, it'll make things a lot easier. So let me just show you what the Michigan telemedicine map looks like. Let's see. So that down there is where my clinic is. And these are all the 10, 11 sites across the state that have telemedicine equipment. The blue ones are the ones that these practices commonly refer kids to University of Michigan. So I primarily see kids from these practices. The red ones are not very active right now. They used to send their referrals to another children's hospital on the western side of the state, but that group is not doing much telemedicine right now. This is the place I was talking about. This drive is 470 miles. So the other question that always comes up is, what about reimbursement? So telemedicine visits are reimbursed by Medicaid and by the Title V program in Michigan Children's Special Healthcare Services. However, some private payers also cover telemedicine. You have to read the fine print a little carefully. Most plans will cover what we call synchronous telemedicine visits, the kind of telemedicines that we do. The store and forward is not yet covered by many healthcare plans. Also, if a patient is at home and connects to a provider over a telemedicine type of network, that is not covered by insurance plans yet. So there is written into Medicaid, I think telemedicine is written into 43 states Medicaid policy. I don't know how much it is enforced though. So when we bill for our telemedicine clinic visits, we bill pretty much as usual, depending on the complexity of the visit. This is an established patient visit, we bill at a level 3, 4, or 5, whatever needs to be done. And then there is a modifier that needs to be added in the billing sheet so that you get the proper credit for it being a telemedicine visit. And it gets coded under the interactive telecommunication visit. This is a screenshot of what our EMR looks like, what our billing screen looks like. And so we just put, whatever visit in here, and then that's the GT is the modifier code. This is not my favorite electronic medical record system, but this is one thing I do like about it. So as we talk about money and telemedicine, is telemedicine cost effective? Now here, this is where good data are lacking. In our little cohort of telemedicine, we've looked at some Medicaid cost savings in the 2010 to 2013 funding cycle. This is not in any way a cost effectiveness analysis. Usually in a cost effectiveness analysis, you have a numerator saying this minus this, and then you compare it to some denominator benchmark, and then you look, do you save money or do you lose money? So this is not done in that format at all. However, just looking at, since Medicaid in Michigan reimburses families to drive from their residence to their specialist's office, the transportation dollars saved over those 3 years was $12,000. Money saved in overnight lodging was about $9,000. Missed days of work and school were almost identical because if the kid was in the clinic, the parent missed a day at work or however. So that was about 200 missed days of work and school. Now it's hard to put a dollar amount on missed work days because everybody does different work and we really did not calculate that. And as I said before, the potential cost savings could include saving money for physicians traveling to rural areas to conduct these clinics in person. So having gone over telemedicine, I want to talk about a different form of telehealth called telementoring. So telemedicine involves direct patient care, provides care within a medical home, at least the way we've set it up. There are smaller number of patients that can be served in one clinic because of the one-on-one physician-to-patient interaction. On the other hand, telementoring is a system where there is no direct patient involvement in that clinic visit. As a result, larger numbers of patients can be touched in a single clinic. And telementoring is designed to build capacity in the primary care workforce to enable them to take care of children with special healthcare needs. So Project ECHO is an example of telementoring. It stands for Extension for Community Healthcare Outcomes. So this project, I think some of you here are familiar with the background of Project ECHO, but I'll go over it anyway. This project was developed at the University of New Mexico in 2003. The project started in the world of adult medicine with the goal to improve access to care for individuals with hepatitis C, which occurs at very, very large rates in New Mexico. And at the time when this project was conceptualized, there was one doctor who was a hepatologist who could treat hep C. As a result, with these large numbers of patients, the wait times in his clinic were humongous, like, many, many months. And individuals who could benefit from medical treatment of hepatitis C were not getting to that treatment in a timely fashion. So this project trains and supports primary care providers in the community to develop their knowledge and self-efficacy on diseases that they usually would not consider within their kind of expertise or scope of practice. It builds partnerships between the community physicians and a specialist. It uses very high quality technology. Even though it is state-of-the-art technology, it's really very easy to use and can be accessed from a computer, from an iPad, from an iPhone or an Android device. The idea is to provide case-based learning and to incorporate specific didactics into a clinic model. So this functions on the hub and spoke model, where the hub, which you see at the middle of the screen, is the specialty clinic, and the spokes are primary care providers who call in from wherever. So there are 4 spokes over here. There could very well be 10 spokes in a given clinic. What the providers perceive as benefit is they receive no-cost CME from the didactic portion of the clinic, and they have pretty much instant access to multiple specialists. I should probably backtrack just for a second and just go over what this hub and spoke model actually looks like. So a didactic session happens at the hub, and it could be, if we're talking hepatitis C, it could be, pharmacologic management of hepatitis C or side effects of whatever drugs that they're using. The spokes actually bring in patient cases that are de-identified. There's a very, very specified format in which the cases are presented, and these cases are then, but this is not like a telemedicine clinic where one side shuts down and the other side goes live. All spokes are live at the same time, and so there's a lot of back and forth discussion. So spoke 1 might learn from spoke 2. They all learn from the hub, but this kind of builds their capacity over time as they, develop these learning communities. So providers like it because they get no-cost CMEs. There is increased professional satisfaction by this level of interaction. In some ways, a medical home concept is maintained even though the patient isn't there, because the primary care provider who is the medical home is taking the care back to their patient. And over time, the primary care doctors become more confident in treating a chronic disease, and it's kind of nice QI activity that they are able to engage in. To the patients, they are getting access to high quality care, but which is within the context of their medical home. They don't have to drive, they don't have to travel. It is by somebody they trust who they have a long-standing relationship with, and patient satisfaction tends to be generally high with the level of care that they receive. So the group in New Mexico actually published their data for outcomes in the New England Journal of Medicine, and they showed that whether you came and saw the hepatologist at University of New Mexico or whether your PCP cared for your hepatitis C in the community without you having gone to University of New Mexico, the outcomes were the same. So these patients did just as well without actually making that travel. So this is when Project ECHO and Pediatrics decided to form an alliance. The American Academy of Pediatrics was awarded a National Coordinating Center for Improving Access to Children and Youth with Epilepsy. And one of the things that happened as part of this coordinating center was a Children and Youth with Epilepsy ECHO was launched. Actually, that was the context in which I met Dr. Wood. Initially, this was piloted at the University of New Mexico for children and youth with epilepsy. There was a multidisciplinary team that University of New Mexico put together with a pediatric neurologist, a pharmacist, a psychologist, a nurse, and then guest experts who would do some of the didactic teaching. And over 1 year, they conducted 49 tele-echo clinics. They did a clinic pretty much every week. They had about 10 providers attend. They presented 20 plus cases, 26 cases, and had a lot of didactic presentations. The clinics were rated as very good or excellent, and generally the attendees thought that they learned a lot. They had the benefits of being able to present and have themselves heard. Some non-physicians, I would say some physicians too, thought that some of the content was a little esoteric for what they really needed. And so, let's see. This is just more of what the providers liked about it. So building on the New Mexico pilot experience, the AAP actually expanded their epilepsy echoes to the state of New York, Illinois, Kansas, Missouri is like a common one, and through Denver Children's Hospital in Colorado. One of the things that we all worked very hard on was to develop a standardized curriculum and also modify how we did these echo sessions. So as against an echo clinic every week, where they ran through topics over a period of a year, our sort of focus group and some of the things that we discussed, what we elected to do was actually come up with 12 or 13 core subtopics in pediatric epilepsy. So recognizing seizures, differential diagnosis, common epilepsy syndromes, medications, some of the comorbidities like ADHD, other coexisting neurological conditions. There's a whole bunch of them. And they were sort of packaged as a 12 to 13 lecture deal. What we asked most of the spokes who would sign on was to try and make it to like a whole session so that they would get all the education that was being provided. But the nice thing was this curriculum ran through 1 year twice. The clinics met every other week. They did not do it every week. But they met twice, and so somebody could either reinforce their learning by listening to the same lecture a second time, or if they had missed something, they had an opportunity to catch it later on. What we also ended up doing was allowing sites to tailor the lecture to suit their audience. So we wanted them to keep the content the same just to keep a standardized curriculum, but somebody could talk a little bit more about this or a little less about that. They could, modify the slides if they needed to. I hope you can read this. These are some very, very preliminary data, and I would suggest don't look much at the New Mexico, that they just had a lot of cases. But the others also have had a handful of sessions with small numbers of cases presented. Again, you have to be careful how you interpret these data, but clearly people have found, what we found was, so this was baseline data that was collected, looking at who felt they were not very knowledgeable about various aspects of epilepsy. And what you see is the percentages drop to some extent. Again, small numbers, so it's a little hard to see how much stock you put in there. But school and education issues, 50% of participants said that they were not knowledgeable. That number drops to 18%. Knowing when to refer to a specialist, 34% felt like they did not know when to refer a kid with epilepsy to a specialist. That's pretty significant to say that now everybody has an idea of when to send kids to a specialist. Similarly, these are some other parameters that we looked at. This was, the first one was their knowledge base and second was their confidence. And again, there is a drop-off in many numbers, particularly when it comes to their confidence in making referrals. So in order to end on time and give an opportunity for questions, I just wanted to end with some future directions that we're thinking of at the University of Michigan is to try and expand telemedicine into more practices in the Upper Peninsula to give some support to the lone neurologist who operates out there. Another area that we feel will really benefit from this kind of collaboration is clinics that are based in schools, so that kids don't even have to miss that half day of school and can get the care right in their school. We would also like to build a sort of tiered epilepsy care system where a community neurologist can connect with a level 4 epilepsy center to get higher level of epilepsy care for some of their more difficult patients. And of course, there is a lot of enthusiasm to expand telemedicine to other disciplines. This work would not have been possible with a lot of people. We have an awesome IT team that provides really excellent technical support. I have Ashley Barnes is my administrator who makes all the scheduling happen. So this, 2-site problem just disappeared when she came on board. Samantha Choi is our ketogenic diet dietitian, and Sarah Clark maintains all our data. Of course, this project is operated through the Michigan Department of Community Health and the American Academy of Pediatrics, and then my division chief and department chair who have been very supportive in making this happen. So I think that's all I have. I think we should have time for questions. Yes?
I'm just curious, you mentioned early on that there was no significant increase in risk for a face-to-face versus telemedicine encounter, but malpractice companies don't always.
Absolutely, absolutely.
Are there extra riders necessary?
So I don't know the full answer to that question. I'll answer it in 2 parts. So the model that comes under a lot of scrutiny for malpractice and adverse outcomes is a model like Project ECHO, where as a specialist, I'm telling a primary care provider what to do for a child with epilepsy when I haven't even seen the patient. Because there is no patient in the picture, it is de-identified. There really isn't a doctor-physician relationship. And so for that model, actually, the legal ramifications have been examined by lawyers and legal experts, and there is no legal binding on the specialist for something like Project ECHO. Now, in telemedicine, that is an area of concern, shall we say. So among other things, most places require a written consent so that the family is aware that this is happening over a video conferencing system, that it is going to be a little different than actually seeing your doctor face to face. And that is also one of the reasons why a lot of people are a little hesitant to do new patient evaluations. If it is a patient with an established chronic condition that you're providing follow-up care, that's very different than seeing a brand new patient you've never seen before. And I think even though we spend a lot of our days and times, texting rather than talking, emailing rather than writing letters, and meeting people face to face, there is still something about that face-to-face, person-to-person contact that you make with a patient that telemedicine so far has not replaced. So some of I think, having the legal issues are obviously the ones that are at the forefront. Legal issues and reimbursement are the two big issues that one has to be careful around telemedicine for. Somebody else had a hand up there. Yes, Colette.
You mentioned reimbursement for the person providing telemedicine. Could you talk a little bit about reimbursement for the other providers?
Thank you. I should have been more specific about this. So again, the way we've got it set up in Michigan, both providers get paid. There's actually a pilot project through the AAMC in adult medicine looking at similar stuff where they actually want to see if they split what we call RVUs, which is a measure of reimbursement between the primary care site and the specialist site, how that works from a reimbursement perspective. Most telemedicine reimbursers, so the insurance companies that do reimburse, will reimburse for this face-to-face when there's a doctor present at both ends, and as long as you bill and document appropriately within your system, it usually gets paid for. So we've examined our billing versus collection at University of Michigan, and I'm not the only person doing telemedicine, so out of about 51 visits that were actually submitted for billing, I think we collected on 49 out of the 51 visits. So it's actually not bad.
When you talk of reimbursement and costs associated with this, we're talking about once everything has set up and you're having that face-to-face encounter with the patient. Can you talk a little bit about what are the initial
Sure.
and what sort of ratio of patients you would need in each center to kind of maybe able to ever meet those costs?
So the main startup costs for telemedicine are that equipment. One piece of equipment with the bells and whistles. So the cart, the screen, it's a high definition screen, it's a very good quality camera. That is about $7,000 or $8,000. But you have one camera at your site, and that's $8,000 worth of, say, investment in clinical equipment that can be used by anybody and everybody. Again, it depends on who is going to incur those costs at various sites. The other place where you end up with incurring costs is sort of staff to actually carry out these, to make sure that these clinics work well. It doesn't take up a lot of staff time, but I think in terms of number of patients, it is not a trivial number of patients, because if you look at what, say, Medicaid reimburses for a return patient visit, it's not a whole lot. But then when you factor in, Medicaid also spends all this money on paying transportation. Medicaid also spends all this money on families getting $50, $60 for their overnight stay, which is actually more than what they would pay the provider. So when you factor in all this, it is likely that telemedicine will come out at least cost neutral. I don't know how much. So those are questions that need to be examined. And the difficult thing in examining that cost savings is what all needs to go into the equation. For example, there is less clinic space utilization. So, that saves the clinic money. But there's more clinic utilization at the primary care end, so that uses more money at the other end. So it's not an easy equation to construct. But in terms of access for the patient, again, it's hard to put a price tag on that.
And at the primary center, like what number of patients would access that one camera that makes it worthwhile for them to have?
So those studies have not been done. It's almost like a power calculation for, when you try to design a clinical trial, it's very similar to that.
What about the IT support at the hub? Can you just tell a little bit IT support at the spoke?
So the spokes that we have some form of EMR. They don't have the same one that we have, so we can't share EMR records. Most places now have at least a computer in the office, so they have even very basic IT support, and it really doesn't take a lot. It's really all you need is, so the limitation to telemedicine in more remote areas is actually bandwidth. So if you lack bandwidth, it can be a problem. And we have had some of those issues in some of the Upper Peninsula areas in Michigan. Again, every year it seems to get better and better and better. But that is a more practical problem rather than IT support, because you don't need much. And quite often our IT guys can, use Zoom or Adobe Connect or something like that and talk to the IT guys at the other end. And I don't understand a lot of that IP language that they talk about, whether they'll have this number and that number. There are a lot of fairly decent IT platforms that are very easy to use also.
How do you get the primary care physician to get on board?
With a lot of talking. Actually, there's actually a better answer than that. So this project is funded by a grant. So we have been able to provide primary care sites with a small stipend to cover some of their startup costs, whether it's equipment, and we've provided them with equipment. Again, this is funded by, a federal grant. But part of it has been actually giving the sites a small amount of money just to help with startup costs. And we've been very liberal and very broad and encompassing as to what they can use the money for, whether it is to support a physician's time because they spend 0.02 FTE per month doing this, or whether it is to support an MA who runs all this stuff, whether their IT person needs a little more support. So we've really let the primary care sites decide where that money is best spent.
And can you discuss telemedicine across state lines?
Great question. So it's not hard to do, but licensing is still a problem, and there is not an easy way to circumvent that. Things are being written into telemedicine policy and law and stuff like that to let that happen, but that by no means is a slam dunk yet.
That's a big issue for us.
Oh, it's a big issue for us too. It's a big issue for us too because, some of the kids who we actually see in our clinic can easily go to Wisconsin, which is, let's see. Oh, so the Michigan map that I showed you, let's just see. Wisconsin is a lot closer than the Lower Peninsula, but a lot of these kids who have, so Wisconsin is actually not very far from here. There's just a lake and then there's Wisconsin. A lot of kids who have Michigan Medicaid, they have to come and see a provider in Michigan. There are some of the borders in kind of northern Ohio who we can see quite easily, but across state lines is very, very challenging.
How did you initially identify the primary care providers that you wanted to invite?
So there were some sort of very stringent criteria that we had. based on how this project was funded. So the kids had to have Title V or Children's Special Healthcare Services as their, at least their secondary insurance carrier, so that billing was not going to be a problem. The other thing we did was we just sort of surveyed our population. I mean, we didn't even like go out and do a survey. We just internally looked at which practices refer to us a lot, and and that's kind of how we got practices on board. Now, there is another way of doing telemedicine where ETSU or University of Michigan could have a telemedicine outpost, in some place. But then you lose the medical home part of it, because if you have, let's say, your own PA or your own MA or your own NP sitting at the remote site, and then you have all your specialists from here connecting with there, you'll probably serve more patients that way, but you lose that care coordination medical home way of doing telemedicine. So we've thought about doing that also, like, for example, putting a U of M telemedicine camera somewhere, like in the Traverse City area, which has a lot of patients who come down and see us, but it's not been something that we've been able to do easily yet. So we've just looked at high volume pediatric practices that refer a lot of patients to us. Again, it is not something that you can walk in to a practice and say, hey, do you want to do this with us? It usually takes months to get the buy-in, for them to go through all the administrative and legal hoops that they have to jump through, for consent documents, for equipment to be bought and delivered, for the IT people to connect. So it usually takes several months before a site who says, yes, we want to do this, that they actually go live. It can take a while. So we have a couple of sites in development that maybe will get on board before this grant cycle ends. Maybe, I'm not sure though, because it ends in 31 days. Other questions?
So aside from increasing bandwidth and having an EHR that talks to each other, what innovations on the side of technology do you think would help telemedicine the most?
So what is happening is the equipment size is getting smaller. A lot of the electronic medical record platforms are incorporating video visits into just their system. So we might not even need to buy specialized equipment. The quality of being able to transmit images. So I still don't do like remote EEGs, or I don't look at MRIs, which are the two kind of big things that I need for evaluating children with epilepsy. We're still not doing that. They are not difficult to do. What I did not talk about was what they call peripherals, which are a huge area of development in telemedicine, where you can actually connect a stethoscope, an otoscope, to a video streaming equipment. And so you could be sitting here and listening to a kid's chest somewhere else. And there are many, many tech companies that are just developing this like you will not believe. They are even talking about doing this from a patient's home to an urgent care. So a kid in the middle of the night wakes up screaming and their ear hurts. A mom can put an otoscope in the kid's ear and you can look at it from your office. Now, talk about the legal ramifications over there. I won't even go there. But those are the kinds of things that are happening quite rapidly. Thank you.